The final speaker in this particular session is Dr. Max Schmulson, who also needs no introduction to this group. He's been involved in this meeting for several years. And Max is Professor of Medicine at the Universidad Nacional Autónoma de Mexico. He's a member of the National System of Researchers of Mexico and was the founders of the Latin American Society for Neurogastroenterology and served as its first president. He's currently chair of the International Liaison Committee of the Rome Foundation, International Associate Editor of the American Journal of Gastroenterology, and Associate Editor of the Mexican Journal of Gastroenterology. Max.
So thank you very much. It is a pleasure for me to be in this important conference as well. And I'll be talking about Latin America. So this is a map showing the prevalences of many studies that have been reported in the region. As you can see, in red are those community-based, and in green, those that have not reported what are their populations, and in white, the volunteers. And I can show you that the prevalence go all the way from 10% in Uruguay up to 35% in Mexico. And let me focus on these studies in Mexico that are from our group. As you can see, when we did a study in a community-based, the prevalence was 16%, but on volunteers it went all the way up to 35%. So these variabilities depend not only on the target population, but also on the criteria that were used for the studies. In all of these studies, there was a higher prevalence of females compared to males, as you would expect. And let me now focus on one important issue, which is the bowel habit subtype. And I'm showing you here the results of several studies of the region in orange IBS-C, in blue IBS-D, yellow IBS-A or M, and green IBS-U in those that use ROM3 criteria. And as you can see, in all of the countries, there's a higher prevalence of IBS-C, except in Argentina, where there's a higher prevalence of IBS-D. If you compare those that were done in volunteers among the community, there's always a prevalence or a predominance of IBS-C in all of these studies. Now, one important issue is bloating. However, this is a difficult symptom to investigate, as there's not a word in Spanish for this symptom. Patients usually refer to it as feeling pregnant, swelling, inflammation, fullness, or even distension. And in research questionnaires, we ask for the presence of the sensation of distension or swelling. The intensity of these symptoms seems to be higher among 30 to 50 years old age group. However, it is very common in IBS, as I said. Almost 97% of the patients report this symptom, and probably more common among the IBS-C. Now, there are several psychosocial factors that have been investigated, and these are some studies that come from an epidemiological surveillance system that is in Nicaragua, and it's led by Dr. Douglas Morgan from UNC, and he has done several studies. For example, intimate partner violence that was studied in 965 women. You can see that in those that fulfill criteria for IBS-C, physical as well as sexual abuse was more common than in controls in this population. Also, he studied the traumatic war experiences during the Sandinista revolution between 1975 and 1979, and there were some significant associations for IBS. For example, in women, witnessing an execution, relative killed or injured, physical or psychosocial abuse, and multiple traumas were related, while in men, only relative killed or injured and physical psychosocial abuse and multiple traumas. They also analyzed the subgroup older than 43 years of age, because they were supposed to be older than 12 years when the Sandinista revolution took place, and all of the criteria were significantly associated with IBS. Now, there are other factors that have been related to the presence of IBS in Latin America, and I'm showing you results from several countries. For example, in Mexico, the first manifestation of IBS was related to history of surgeries in 26%, emotional factors in 22%, other organic diseases in 15%, and previous GI infections only in 6%. And this is probably the only available study that may show you the prevalence of post-infectious IBS, besides the study that is now being run by the European Federation of Gastroenterology. Now, about food triggering or exacerbating symptoms in IBS, fatty food, spicy or seasoned or legumes were associated but not relations to artificial sweeteners. In Guatemala, in patients consulting to GI private clinics, a past history of parasitic infections was reported in 49%. However, in this more well-designed study in Nicaragua, there was no difference in the parasitic burden between the IBS and the controls, and there was no difference in the risk of IBS with pathogens or commensals. Also, socioeconomic factors did not affect the IBS prevalence. And in Brazil, this other study by Carlos Francisconi showed that it was related to lower socioeconomic level and younger age. And in Chile, again, there was no difference according to the socioeconomic level. Now, what are the reasons for medical consultations? And this is a study from Mexico. We analyzed these factors that you can see here. As you can see, the overall intensity of abdominal pain, discomfort, symptoms, stressfulness, impairment in daily function, or fear of cancer was not different according to the patients. However, the self-reported importance of these symptoms in relation to seeking medical care was higher for abdominal pain or discomfort or symptoms, stressfulness. And these were more related to the presence of anxiety and depression and impairment in daily function with depression. And some of these factors had some impact on health-related quality of life. Also, which are the providers that they seek medical attention to? So as you can see, this is a study from Colombia. There's a higher risk to consulting to general practitioners and specialists, followed by specialists, but the alternative medicine providers is also an important factor. Now, what is the satisfaction with pharmacological treatments? And as you can see, 15% of patients in a multi-center study in Mexico reported that had received a previous treatment. However, only 51%, I mean the majority, 51% considered to be satisfied with this treatment, and 29% said that they were not satisfied at all. So there's an unmet need here, and they are also consulting very frequently or using very frequently CAM, 51% of the IBS patients, and interestingly, 55% of these patients that used CAM, the source of recommendation for this type of treatment was a relative, while 33% was from a friend, but even 4% from physicians. Now, there's an excessive workup investigations in patients. At least this is a study from Mexico, in only 98 patients that were having only IBS with no any comorbidities or any other associated illness, and the diagnosis of IBS was given in the majority of them during the first diagnostic visit. However, 98% of them were underwent investigations or testing, and the majority of this testing were done after the diagnosis was given. And you can see here the list of all the investigations that were ordered in these patients. Now, is it important to have a limited diagnostic workup in patients fulfilling ROM criteria? And this is another study from Mexico where they only analyze the importance of these studies that have been recommended in several guidelines, as you can see here. And at least one abnormality in any of these testing was found in 64% of the patients. Now, when they analyze if there was a change in diagnosis, and remember these are first-time consultants, patients that consulted for the first time, they found that the frequency of at least one organic disease was found in 28% of them, and 55% of them had Giardia. What it means is that when you see a patient for the first time, you are supposed to rule out at least other diseases before giving the diagnosis of IBS. And anxiety and depression are also very commonly reported in these patients. Anxiety was found in 70%, depression in 46%, and both in 40%. What's important is we related the presence of anxiety here in orange, or without anxiety here in blue, with the number of days a week with abdominal pain, and you can see that those that had anxiety had there was a higher percentage of those with anxiety with higher numbers of days a week with abdominal pain, and the same was true for the presence of depression. Now, we don't know if depression or anxiety are the consequence of the abdominal pain or the presence of abdominal pain is the cause of anxiety and depression. In conclusions, I would say that in Latin America, IBS has a prevalence that ranges between 11 and 26% in the community, and IBS-C is the most common subtype. Although there is not a word for bloating, this symptom is very commonly reported among patients with IBS. IBS has also been related to previous war experiences, intimate partner violence, and spicy and fatty foods, but not to educational or socioeconomical level. Although it has not been related to parasitic infections, it is necessary to rule this out before diagnosing IBS. Abdominal pain, discomfort, and symptom stressfulness are the factors most commonly driving medical consultations in these patients. General practitioners are the most commonly visited physicians for IBS, while gastroenterologists are the least common ones that have been consulted, and I didn't show you this data. Consultation to providers of alternative medicine and CAM is most frequently used by patients with IBS than controls. And I didn't have time to show you this, but IBS produces not only a high use of medical resources, such as an excessive number of clinical investigations, work absenteeism, and has a negative impact on work productivity and health-related quality of life. Thank you very much.